Hello everyone. Today we will discuss about hirsutism. Hirsutism is a quite important topic both clinically as well as in theory exams. In clinical practice, it is quite common for you to see hirsutism in young adolescent females as well as even adult females. Hirsutism is defined as the presence of excessive terminal coarse pigmented hair in androgen-dependent areas of the female body such as face, chin, chest, abdomen, thighs, and back. Hirsutism reflects increased androgen production or increased sensitivity of hair follicles to androgens. It is a common endocrine presentation and may be benign as in idiopathic hirsutism or may indicate serious underlying ovarian or adrenal pathology. It usually affects 5 to 10% of reproductive age group women, more prevalent in South Asian, Middle Eastern and Mediterranean women due to genetic and ethnic sensitivity to androgens. PCOS, which is recently retermed as PMOS, accounts for 70% to 80% of all the cases. Idiopathic hirsutism accounts roughly for 5 to 15%, whereas androgen levels are normal here and the follicles are hypersensitive. In androgen secreting tumors, which is though rare, it must be ruled out, especially in rapidly progressive cases. Onset is usually gradual in PMOS, but rapid progression over months indicates tumor and requires urgent evaluation. Coming to the risk factors, the first one is genetic or ethnic, wherein there will be a family history of hirsutism and higher prevalence in ethnicities like Mediterranean, Middle Eastern, and South Asian. Then endocrine conditions like a PMOS, congenital adrenal hyperplasia, late onset one, Cushing syndrome, ovarian hyperthecosis, hyperprolactinoma, hypothyroidism. Metabolic abnormalities like insulin resistant central obesity, hyperinsulinemia then increases the ovarian theca cell androgen production. Drug induced like anabolic steroids, danazol, phenytoin, minoxidil, cyclosporin, DHA or testosterone supplements can cause hirsutism. Neoplastic causes like androgen secreting ovarian tumor, Sertoli Leydig cells or granulosa theca tumors, and adrenal virilizing tumor or carcinoma can also cause hirsutism. The pathophysiology lies in excess androgen production in the ovarian or adrenal glands. This results in enhanced peripheral conversion of testosterone, wherein the dihydrotestosterone at the hair follicles, and increased sensitivity or increased number of androgen receptors in the hair follicles is also a cause, which will result in prolongation of the anagen phase leading to thick terminal hair growth. The clinical features include there will be hair growth in androgen dependent areas that are affected, usually associated with acne, oily skin, acanthosis nigrans in case of insulin resistance, menstrual irregularities like oligomenorrhea or amenorrhea, weight gain and central obesity, infertility, which is very common in PMOS. The red flag features suggesting tumors include deepening of voice, clitoralomegaly, breast atrophy, increased muscle mass, and rapid onset within months. So, Ferriman-Gallwey score is the score that is used for hirsutism. So, the 9 scored areas are upper lip, chin, chest, upper abdomen, lower abdomen, thighs, upper arm, back, and buttocks. Each area is scored from 0 to 4, in which 0 there is no terminal hair and 4 indicates extensive terminal hair. The interpretation is if it is 0 to 7 it is normal, 8 to 15 mild hirsutism, more than 15 moderate to severe hirsutism. Very rapidly high scores can be seen in suspected tumor. So coming to the investigations, hormonal test wherein the total testosterone where there will be increased ovarian causes, increase in DHEA which results usually due to increased in adrenal tumors or congenital adrenal hyperplasia, 17 hydroxyprogesterone for CAH and LH or FSH ratio which is increased in PMOS, prolactin in hyperprolactinemia, and TSH and T4 due to hypothyroidism. The metabolic tests include fasting glucose, insulin and lipid profile, imaging mostly pelvic ultrasound, adrenal CT, MRI or ovarian imaging for tumor suspicion. Depending upon hair type, distribution, cause and hormonal levels, it can be hirsutism or hypertrichosis. In hair type, it will be terminal in hirsutism and wellness or terminal in hypertrichosis. It will be specific in androgen dependent bodies, whereas hypertrichosis will be present all over the body. High androgen action is the thing behind it, whereas genetic and metabolic drugs are behind hypertrichosis, and hormonal levels are often raised, but it is usually normal in hypertrichosis. Coming to the management and style, lifestyle management is the first thing. Weight loss is the single most effective non-drug measure. It reduces insulin resistance and androgen production. Cosmetic, laser hair reduction, electrolysis, depilatory creams, and waxing, threading, and shaving can be done. The medical management include combined oral contraceptive pills, which are the first line therapy, which suppresses the ovarian androgen production and increases the SHBG and decreases free testosterone. Next is anti-androgens. It can be used only after 6 months of combined oral contraceptive use or in resistant cases, and these include spironolactone, cypritone, acetate, finasteride, which is contraindicated in pregnancy. The medical management further includes the metformin in PMOS, which improves ovulation and reduces the androgen levels, steroids, low-dose corticosteroids for congenital adrenal hyperplasia, and treat the underlying conditions if it is thyroid replacement, dopamine agonist for hyperprolactinemia, and surgery for adrenal or ovarian tumors. Coming to the complication, first thing is psychological stress, that is low self-esteem, then infertility due to PMOS, metabolic syndrome, and tumor related morbidity if malignancy is the cause. To summarize, hirsutism is excessive growth of coarse terminal hair in androgen dependent areas of the female body such as face, chest, abdomen, thighs, and back, and it is most commonly caused due to polycystic metabolic ovarian syndrome, which accounts for nearly 70 to 80% of the cases. The Ferriman-Gallwey score is used to grade severity based on the hair growth in 9 anatomical areas. Risk factors include insulin resistance, obesity, congenital adrenal hyperplasia, Cushing syndrome, thyroid dysfunction, hyperprolactinemia, danazole or phenytoin-like drugs. Management involves weight reduction, combined oral contraceptive pills, anti-androgens like spironolactone or cypron acetate, insulin sensitizers like metformin, cosmetic methods such as laser therapy, and with special attention to rapidly progressive cases in underlying tumor. So I hope you have understood through this presentation. Thank you for watching.